Hi, if everyone could take their seats, we're going to get started in just 20 seconds.
Right, send it off. Right.
Yeah. Maybe he's looking for. Be aware of that. Everything is very clear. Mark, we're going to get started. Mark? Mark?
We're late. We just may need to go out of order.
Yeah, we have to go out of order, yeah. So apparently she's not here. And I was walking back to find out what Claire had learned, but.
Okay, that's fine. Well, good morning, everyone. We're so excited that you are here bright and cheery and early, on time for our 7:30 a.m. At first, I thought it was going to be 7:30 p.m. I was very excited, but 7:30 a.m. meeting. And so I'm Marie Bakaitis, one of the co-chairs. To my right.
I'm Mark O'Rourke, one of the co-chairs.
And
Robert Kraus.
And we are the Palliative and End of Life Committee. So welcome. We're going to start our morning first by reminding everyone of our mission. As you know, I think we're still the rookie committee for SWOG, and very proud of that fact. We've achieved a lot despite our rookie status. And our mission is to develop innovative palliative and end-of-life care trials that address high priority symptom management and care challenges. And we've identified 5 objectives, and I'm not going to read them to you. You can read them here, but our focus is on communication challenges, advanced care planning, increasing scalability of our palliative care models, leveraging telehealth and other technologies, and disseminating these effective palliative and end-of-life care models throughout NCORT, and I would say also the world. We are, again, in a sort of a continuing growth and strategic planning time, and so we are going to be revisiting these as our committee continues to meet over the coming year and see whether we're in need of any updating. So let's move right into the program. First, I want to call on our committee liaison updates from our advocates and our research professionals. So here you can see our advocates, and Lee, Carol, and Valerie. Do you want to come up to the mic in the front here, or I mean at the floor there, and give your updates, or you want to come up here? Either way is fine.
Marie?
Yeah, come on up. Sure. And better so you could be seen by Zoom. And oh, I'm sorry. Welcome to everybody who is in our Zoom world for this hybrid meeting. Very excited to have a nice representation of 28 folks on Zoom. So I definitely don't want to leave you out and forget you. Carol, let me.
Okay. I was able to attend the Oncology Clinical Pathways Congress in Boston. And this is, I've always heard about pathways sort of up in the sky, but this was a very specific tool that many institutions are using, and it's described as alleviating care teams of the administrative burden of determining treatment options. And it includes decision support tools that can, reduce the need for prior authorization through an automatic screen. This is an example of NCCN's authorized protocols. The big takeaway that I had was that one large system, which was Kaiser, and I think there are others, when the physician, the team could see the information on the screen for that specific patient, the first treatment option was always listed as a clinical trial. Now, I think it's highly unlikely that a newly diagnosed cancer patient would be offered a clinical trial as their first treatment option. But my takeaway in our DEI mission is that this might be one small step in making sure that all patients are told about clinical trials, giving them a chance to think about it, talk about it, learn about it. I think we all know that this DEI process is going to be step by step, small steps, learning processes. And I thought, well, this might be one trigger of bringing up the topic to a patient. So if any of you have experience with pathways in your institution, perhaps we could talk a little bit, because I'd like to learn more about how it's used. Thank you.
Carol, thanks as always for representing at these various meetings. Appreciate it.
Good morning. My name is Lee Jones, and my relationship with this committee is mostly been involved with supporting Dr. Sun on the very successful S1820. I've been involved since the very inception under Dr. Kraus when it was part of the survivorship committee, which is what I primarily support. I'm very pleased that it is completed accrual and close to new accrual. And I really look forward to helping disseminate the results of the study to my communities, which are colorectal cancer. So I'm a colon cancer survivor, so been very much involved with colorectal cancer committee organizations, advocate organizations. So look forward to communicating the results when the results have been completed. Most of the work that I do in advocacy is related to actually drug clinical trials, serving on IRBs, doing work with ASCO and Friends of Cancer Research. So actually, this is kind of a very interesting, different group that I'm working with. But it's also very interesting, being a metastatic cancer survivor, I really can understand and appreciate the work that we all do here and how necessary it is. So thank you.
Thanks, Lee. We really appreciate also your continuous support of our patient-oriented studies. And we have Valerie Frazier on remotely. So Valerie, I can see you. We can't see you on the screen except for your picture, but the floor is yours.
Okay. Yeah, my video's on, so I don't know why you can't see me, but I just want to say good morning, and I'd like to just give a little overview of some of the things we've done in Palliative Care End of Life Committee, just a few things this year, and also some highlights of the work we do in PAC. So I want to thank Lee and Carol for giving a little bit of background too on some of the things that they've experienced at the conference and outside of the conference. We've had several things we're involved in that I was excited about and I think made an impact. And that was all three of us were involved with the pilot study with Jamie Myers, which was a PREPARE study for advanced care planning for patients with advanced disease. And that proved helpful in many ways in shaping the future development and the direction of the project. And then recently, Drs. Feldman, Korn, and myself worked together to develop a presentation, which we just gave to the World Cancer Congress on the science and practice of hope as an emerging tool in oncology. And that's available on demand on their conference site. So if you get an opportunity, take a look at it. I think it was very well done. And I have to thank Dr. Feldman for all his technical expertise with putting that together. And as research advocates, we also work with our colleagues in the PAC committee, as I explained, and we share ideas and develop ongoing resources that support SWOG and are meaningful and impactful for patients. So I'd briefly like to highlight some of the resources and work of PAC that support SWOG research and could also be a benefit to our work on this committee. So ongoing, we have a PAC community advocate program I was involved with that in recruitment and helping in that program. We currently have 5 community advocates representing the Latino, older adult, LGBTQ, adolescent, young adult, and veteran communities. And there are 5 more community advocate positions still to be filed. Community advocates will work across SWOG committees to provide a frontline patient view and voice for their communities. And we also recently onboarded Laura Asfeller, our new kidney cancer research advocate, and developed a new patient advocate emeritus specification. And we updated and improved our advocacy guide, which is a roadmap for advocates in their work with SWOG. And team science, as you all may be aware of, is a useful tool in the study life cycle, which is an ongoing project for our committee. It consists of a series of modules that provide guidance and advice of how to support patient and advocate engagement across the life cycle of a study, accessible through the SWOG learning management system. And this year, we completed our latest edition, which is Module 6, providing guidance on improving the diversity and representativeness of clinical trial participants. In our PAC meeting this year, we explored that further, and we will continue to work with membership leadership, DEI champions, and other support committees as DEI is further developed and rolled out within SWOG. And DEI champions will be working on pilots in 5 communities in the breast, GI, GU, lung, and myeloma committees. And they will be there to support pilot committee trials. So this is an exciting time for SWOG researchers and advocates. And we are thrilled as advocates to be a part of the important work taking place in our committee. And we look forward to working together for our continued growth and the promise of new emerging concepts and trials yet to be. So thank you very much.
Valerie, that's a great update, and we've been hearing so much about the incoming community advocates and the DEI efforts throughout this meeting, and so we depend on you and the other advocates to keep us up to speed, so thank you very much. Given that this is Chicago and there's this thing called traffic here, our speaker, who is from Chicago, is running a little bit late due to that very topic. And so we're going to switch the agenda around a little bit. And as she's here and arriving, and move on to our developing study update. So, Robert?
Okay. So our first speaker is Jonathan Sham. Jonathan's an assistant professor of surgery at the University of Washington. He's also been awarded a Coltman Fellowship and towards this study in a high-risk population, pancreatic cancer or pancreatic surgery patients. So I'll let Jonathan talk about his proposed study and where we are.
Thanks so much, Robert. Thank you so much for the committee for the opportunity to speak, and the co-chairs for accommodating a busy schedule with overlapping responsibilities over in GI. So thanks. So let's see.
You have the clicker.
There we go. Oh, perfect. So I'm here just to give a very, very brief update on where we are with our project and kind of where we're going. As a brief kind of note of disclosures, funding for the phase 2 trial that we just published on this topic was provided by Ipsen Biopharmaceuticals. That's going to come into play, you'll see in the end. So just very brief, because I know that there may not be a lot of surgeons in the group, but pancreas leak, pancreas fistula, what is that? It really is the defining complication after pancreas surgery. Whenever we cut into the pancreas, it's like a soft gland. Some people describe it like tofu, and so you have this leakage of enzyme-rich fluids, normally meant to digest your food inside the intestine, but they can leak out into the abdomen and cause a lot of problems: infection, bleeding. It's linked to other complications like post-bacterial hemorrhage, DGE, which is delayed gastric emptying, sometimes keeping patients in the hospital for extra days to weeks, infection, reoperation, and in some rare cases, even death. Well, we've really improved outcomes after pancreas surgery over the past couple of decades. Really, the rates of fistula haven't budged. They're about 15 to 25% after Whipple and 20 to 30% after distal pancreatectomy. So our population that we're looking at is quite broad intentionally. Essentially, anybody getting a distal pancreatectomy for malignancy or suspected malignancy. Oftentimes when we go to the OR, we don't know definitively they have cancer. We just have a strong suspicion, and not every patients get biopsied. That's really standard of care. And then you can see exclusion criteria if they were given a drug similar to lanreotide in the past, malabsorption syndrome, pregnancy, etc. So this is the schema as it stands now. Since I presented at the spring meeting, this has really been pared down a bit. We had this grand plan of a Whipple and distal arm. It got a little complicated. I heard the word feasibility about 1 million times, and so we really narrowed it. Interestingly, since then, and since we narrowed it kind of independently, a meta-analysis came out looking at the use of somatostatin analogs in pancreas surgery. And really the strongest signal was in distal pancreatectomies, and that matched our phase 2 data as well. So that really excited me because it was kind of validation for us and where we're headed. Again, the primary outcome is still this grade B/C pancreatic fistula as defined by the ISGPS. Secondary outcomes looking at leak, those are the kind of these like small leaks, hip bleeding, delayed gastric emptying, and then other kind of important perioperative outcomes like how soon do they get chemotherapy after surgery, how long do they stay in the hospital. And then what I'm really excited about is some of the exploratory outcomes like quality of life metrics that we've been developing. And I can show you here, we've been working with the ProCore team to develop this, I should say promise, sorry, a little misprint there. This 30-question quality of life metric, looking at some of the variables here that you can see that are important in the perioperative setting, and we think are affected by this outcome. So just again, as a summary, due in large part of the support of this committee, Dr. Krause, Catherine Guthrie, who I see is in the audience, Gabby Curian, we were lucky enough to receive the Coleman Award for this work. We're actually working with kind of groups across SWOG and really have gotten a lot of green lights everywhere we've looked, but the current holdup now is working with the drug company. The company that was originally sponsoring this, Ipsen, has told us that now the drug's gone off patent, they're no longer willing to support it. We're currently working with a generic company who's now producing it, and it's in use across the country. But as they're a generic company, they don't have the same clinical trials infrastructure that other larger companies have, so we're dealing with some of those hurdles. But I'm still confident that I think we can get this through. And that's it. It's a brief update. Happy to take any questions.
Great. Let there be a question.
Not to belabor it, do you mind just expanding a little bit on what the issues are with the drug company or the plan, or?
Yes, I would love to. I didn't want to bore anyone. So we went to them, the company Cipla Pharmaceuticals. They expressed interest and excitement for the trial. Our medical affairs contact presented to their board, and there were concerns from a regulatory standpoint that if they were to provide drug, and this is going to sound ridiculous, but this is what we were told, if they were to provide drug, it would be an in-kind donation, and they might run afoul of federal regulators for an in-kind donation. Now, I think the reason where this is coming from is this is a generic company. They have no clinical trials infrastructure. They don't understand what SWOG and CTN, they don't know anything about that. They're just used to making drug, right? And so I'm hoping with some education, perhaps some help from SWOG regulatory experts, that we can iron this out. Right now, their plan is to roll out an IIT mechanism that we could apply for. Who knows how long that's going to take, but again, I'm confident we can get by this, and I'm hoping it's just because of their relative inexperience with the clinical trials world.
Great, thank you.
And
Robert?
it's why we're also meeting later this morning. So thank you for that. Okay, so we're excited about that moving forward, hopefully in the future. So next, Vincent Chung is going to give update on his palliative care and pancreatic cancer trial, which has gone through different iterations, and so we maintain as a committee very excited about the future of the study.
Great, thank you. Slides. Well, first of all, good morning, everyone. It's great to see everyone in person again. And on behalf of my co-PI, Virginia, I want to give you an update on S2016. Also want to thank the committee for inviting me to speak on this. And we're really excited about the new revisions that we made and the grant resubmission we just had. You got the slides, by the way?
You have the clicker. You're in control.
Wonderful. So this is S2016, the randomized phase 3 trial of palliative care intervention to improve quality of life in metastatic pancreatic cancer patients. I want to, thank our advocates. They really helped out in terms of, with the design of the trial. Catherine Guthrie for making those last-minute meetings as we had our most recent grant submission. Yeah, screen's going up. So just give you a little bit of background again. I'm just going to kind of reiterate what we kind of talked about in the previous meetings. Palliative care, of course, an important aspect of pancreatic cancer patients. As we know, our pancreatic cancer patients have a lot of symptoms, and aggressive symptom management is actually really key to being able to tolerate treatment. Palliative care is the gold standard for cancer patients, and there's a significant shortage of palliative care physicians. So it's going to be challenging to kind of meet our current as well as future demands. And it was wonderful to see that the mission statement for this committee really kind of fits in with this particular proposal. So I was really happy to see that this actually project is really following the mission statement for this committee. So we are trying to develop scalable approaches to meet this growing demand for our pancreatic cancer patients, and a comprehensive patient assessment administered centrally is one way of achieving that goal. So we're really excited about our most recent grant submission. I just want to kind of highlight some of the key things that we actually did with this current resubmission. Number one, we really wanted to kind of think about how our pancreatic cancer patients are surviving longer. So previously we had actually submitted a palliative care concept. This is really more of a survivorship concept because we're seeing that our patients are living longer with pancreatic cancer. One of the things I think is actually having a major impact is not only clinical trials, but also palliative care. And we're going to really evaluate in this particular proposal how palliative care, which increases symptom management, quality of life, may actually then translate into improvement into clinical trial enrollment. We have the fortune of being able to partner with PanCan, which is the largest patient advocacy group for pancreatic cancer patients. And they have a really robust pancreatic cancer clinical trials searching program, and also counselors that are able to really direct you and educate you in terms of trying to get to the right pancreatic cancer clinical trial. The other thing that's really happened over the last couple of years is after the COVID-19 pandemic, telehealth has really become a key part of delivering care, especially for patients in communities that may be more undeserved. And we're going to really utilize, the Doximity telehealth platform to really be able to reach out and connect with the patients. Now, this is a true story. For those of you that don't know about Doximity, Doximity is actually a very, very useful app, which is very easy in terms of being able to connect. Most of the patients out there probably will have a smartphone. There will be some patients that don't have a smartphone. But if you have a smartphone, you can easily send them a text message, and they actually click on the link, and they're able to actually get on a televideo visit, which is HIPAA compliant. So this is the study schema. Patients with metastatic pancreatic cancer, as well as their caregivers, will be randomized to one of two groups, the intervention arm or the intention control arm. In their intervention arm, they'll actually undergo 6 telehealth Doximity visits. And they'll also be educated in terms of clinical trials by directly connecting them to PanCan. And we also have actually nursing educational tools for pancreatic cancer clinical trials as well. We are looking for an improvement in terms of quality of life at 3 months and 6 months. And we're also looking at 6 and 12 and 18 month time points to really evaluate the accrual onto clinical trials. So we're looking at really kind of impacting different aspects of clinical care, and this is really based upon the aims that were evaluated in the National Consensus Guidelines. So we're looking at physical aspects of care as well as spiritual, psychological, and social aspects. Being able to do this with a centralized nurse and delivering this via telehealth. So the first two aims are really looking at the survivor as well as the family caregiver. And the third aim is really looking at clinical trial enrollment. So we are looking at trying to accrue 170 evaluable patients, and we're going to need 238 patients total, anticipating 25%, 5% ineligibility, and about 25% loss to follow-up. So we anticipate this will take about 2 years in terms, actually 4 years to complete accrual, with 4 to 5 accruals per month. And we did submit the grant just in October the 3rd, 2022, so just a couple weeks ago. So we're looking forward to hearing back from the beginning of the year. So I'd be happy to take any questions.
Questions? We will allow one question.
I have a question online.
Oh, perfect. Okay.
So this is Katie Arnold from the Stat Center. Catherine might actually be able to address this. I'm curious about the clinical trial enrollment objective and if this involves the number of screening patients. And if it does, how we're going to support the sites in that aspect of the study, because they don't get paid for screening, they get paid for enrollments.
Paid for enrollment in.
So I think she's asking about how to support the screening activity of patients.
Actually, it's the tracking of the screening. SWOG doesn't usually track screening.
Oh, yeah.
And so it's actually quite an effort to report it back to us. I've done this in a couple studies, and it's really labor intensive. But they don't get paid for it. They get paid per capita for registrations to studies. And so I was just wondering what that objective, what that aim is really about. Thank you.
Oh, speaking, make sure it's on.
Is this on? Oh, it is on. Okay. I just need to get it up to my mouth. So yeah, I had a lot of questions about this too, how we're going to collect that data and access it. I think we decided that it would be basically a patient-reported outcome.
Yeah, exactly.
Because as you say, the connection through the site is not going to be useful on that front, like tracking whether they screen into or consent to another trial. Won't be accessible.
Yeah, exactly. I mean, in terms of, when we're talking with PanCan, just because they do have a robust database, we'll be able to actually go back and, the patients that are in the intervention arm will be able to, again, look in terms of seeing like what trials they did accrue to, because they do have a follow-up mechanism. As far as the patients that are in the attention control arm, we're not preventing them from actually going and, reaching out to PanCan on their own. We're just wanting to be able to collect the data to see how many patients actually do reach out on their own, do get connected. So we want to be able to see that there's a difference between the two arms.
So this is clinical trial participation beyond your clinical trial.
Yeah.
Thank you.
Great, we appreciate the questions, and maybe we could close for now and revisit and contact, others can contact offline with additional questions.
Okay, so the next developing study has gone through some twists and turns. It's the study looking at depression in patients requesting medical aid and dying. The leader is Yara Salman and Charles Blanky, and Dr. Blanky is going to give us an update of where we are in that study.
Good morning.
Good morning, and thank you. Do I have anything pointer-wise, or is it just?
I think there's a
It's
pointer
okay.
on there.
Okay, you'll just have to follow my voice. So this really has been quite the saga. It was S2106 a couple of years ago when you guys first talked about it. Now it's S2X06, and we're hoping the X is a 3. In terms of what's been going around, just to remind you, the original concept was actually a phase 3 trial that was going to test whether treating depression in patients at end of life actually lessened their desire for medical aid in dying. But it quickly became apparent that we had insufficient background information to really adequately power the study. We then proposed a phase 2 trial to actually determine the rate of depression in this population seeking MAID, but the steering committee had a number of concerns. Most of them seemed to be based on the actual feasibility of doing that type of trial. And then suddenly a gift from heaven, this U34 planning grant came along. At least we hope it will be a gift from heaven. So just for those who haven't seen this particular mechanism a lot, it's a cancer prevention and control clinical trials planning grant with an optional clinical trial. The stated purpose is to support studies for the acquisition of data critical to completing the protocol of a large or full-scale multi-center phase 2 or later phase trial. The immediate goal is the acquisition of information scientifically necessary and sufficient to permit final decisions about design or conduct. And then some of the reasons you might apply for the U34 all seem to apply to this trial that are shown in bullet number 3. This mechanism might be useful when investigators don't have information about the population, the intervention, the tool, the outcome, statistical planning, or operational risks. So the population's a maybe, because I would argue we really still don't know the rate of depression, and everything else is a definite. We don't really know whether these patients who are usually in a big hurry to get the medications would even be willing to be screened. The use of the tool in this population needs to be validated. If they're actually found to have depressive symptoms, would they be willing to be referred, even if we could do it quickly, to psychiatry or psychology? And would we actually be able to get them in within the 15-day period that's mandated by most states as a cooling off period for those seeking death with dignity? So basically, we wanted to, as part of the pilot study associated, assess the feasibility of universal depression screening using the PHQ-9 in a nationwide cohort of patients with cancer making their first verbal request for medical aid in dying. Research objection 1 was to determine the proportion of patients seeking MAID willing to complete the actual tool. 2A was to see the proportion of those who screened positively for moderate or greater depression, a score of greater than or equal to 10. And then basically we wanted to see if this was variable across the US. There's reasonable data that came out of Oregon a few years ago, but we want to see if it's reproducible and how that would actually impact upon doing this trial nationally. And importantly, objective 3, these might be sites that don't normally participate in cancer control and prevention or any in-course studies for that matter. So we wanted to see if the network of subspecialty sites that offer MAID are actually able to do this type of research, especially for that phase 3 trial later. As the secondary objective, we wanted to estimate the rate of acceptance of mental health referral and treatment for patients seeking MAID who did screen positively on the PHQ-9. So research objective 4 is to determine the percentage who screen positively who agree to that referral. Number 5, we want to see whether they are truly depressed or not as assessed by a professional, a psychiatrist or a psychologist. And then 6, we want to see if they will agree to treatment, yes or no. Remember, this treatment has to be very, very quick acting because again, we probably have about 15 days or fewer. So it's likely, according to my co-PI, that it will be megadose ketamine or incredibly intensive but very brief course psychotherapy. So in terms of what's going on, we have a WebEx meeting with the U34 program officer. We've already forwarded these objectives in just a week or so. It's interesting, and of course we want to see what the NCI ultimately says, but the ultimate trial probably will also in some way involve cancer care delivery. For those who, again, haven't applied for these before, the award is $225 per year and $600K in direct costs over a 3-year project period if it has an associated trial, which we do. And we are currently aiming, depending on what the NCI says, for a February submission with the earliest start date being December. Thank you. Uh-oh.
There's time for questions?
No, we're out of time. We're out of time. Good morning.
Good morning. This is Lori Manassian from the NCI. Thank you for the comment about the gift from heaven. This is a brand new mechanism that this is the first time the NCI has used this mechanism, and we would really like to see it used more often. We think it's a wonderful way to get funded to do a lot of the pilot work. It's both, there is an FOA for both the U34, which is intended to be used in preparation for any of the clinical trials networks. And there's an R mechanism also, if you intend to do a pilot study for an R01. We are thrilled to have it out, and we hope it's a successful mechanism for helping improve the ability to get the randomized phase 2s or phase 3s done. Thank you.
I appreciate that. I mean, I've obviously participated in a few grants over my time, and when I saw the RFA, I thought that it was written for this trial.
Yeah, Frank Maskin. My concern is even with the U34, which is a wonderful mechanism, that the data so far that has been done of all the MAID studies have shown that depression is not a significant contributor.
I don't totally agree with that. So one of the reasons do we have time for this?
Yeah. Just.
One of the reasons we originally wanted to do the trial is we were being lambasted in Oregon and elsewhere by psychiatrists who didn't reside in Oregon, who said that depression affects judgment, not necessarily decisional capacity, but judgment. And it's been published extensively that you should not offer MAID to people who are depressed. Now, the rate of depression in this population, as you know, Frank, is somewhere between 25 and 77%. So if it really does affect their decisional capacity, it's important to know. And we do actually know that treating depression does affect the desire to die at end of life in similar populations. So I would argue that this is unknown rather than already determined. Excellent. Thank you guys so much for having me. I'll see many of you later today.
Yes, you bet. Thank you. So we're going to move on to our active study update and call Dr. Sun to the podium. Our plenary speaker is here, but we're letting her breathe. And we'll move on to our plenary in just a few minutes. You have the clicker.
This is the slide for James.
So we got
Oh, whoops. I guess we're, that's, all right, see what, if it's right after that.
these are, here she is, okay.
Okay, yep.
All right. Thank you so much for the opportunity to be here, and it's wonderful to see everyone. A quick update on SWOG S1820, which is a randomized trial of the altering intake, managing symptoms intervention for bowel dysfunction and rectal cancer survivors, which is compared to a healthy living education control. This is a feasibility and preliminary efficacy study, and we fondly call our intervention AIMS-RC. We appreciate the support from the NCI within R21 and the Hope Foundation for Cancer Research, STRS clinical trial support funds. I want to very much appreciate everybody on this team. It takes a village, as all of you know, to bring a concept to the table and then be able to actually activate and conduct the trial. So many thanks to my co-chairs, Dr. Cynthia Thompson at University of Arizona, Dr. Tracy Crane, who is actually now at the University of Miami, Sylvester, and Dr. Krause as our committee co-chair champion. Catherine Guthrie, thank you so much. And Katie, I know you're on the call. Every week, this team meets, since we started this trial, and appreciate everyone's hard work. And Roxanne, in terms of the data operations and management component. Christy for protocol coordination. We do have a PRO quality of life nurse coordinator, Dr. Krista Braun-Inglis, who I think have left already, but her input from the NCORP side has really been helpful in terms of helping us adjust and think about barriers in terms of accrual. Many thanks to Lee and Valerie for your help with this trial. Lee, particularly since day one, when we were working on this. I actually started developing this trial as a young investigator, participating in the Young Investigator Training course. So thank you very much. And of course, we have GI committee champions, Dr. Mazen Al-Kaspuls for the surgical oncology side, and Dr. Stacy Cohen, medical oncology, and all of our coaches and study coordinators at the University of Arizona. So just very quickly, this is a randomized trial. So patients, we enrolled 94 participants. These are rectal cancer survivors between 6 to 24 months post-treatment completion. We did enroll ostomy and anastomosis participants. They had to have a low anterior resection syndrome score of 21 to 42, which indicates minor to major symptoms, and 18 years and older, and English speaking for this trial. They were consented, completed baseline, and we did include a run-in period, which included a 14 to 21 day kind of of giving participants a flavor of what is to be happening within the intervention. So they did complete a 24-hour dietary recall, 3-day food and symptom diary, And during this time, from once they complete the run-in, they were randomized to either the intervention arm, which is our AIMS RC intervention. It's a 10 telephone coaching call over a 4-month intervention. We have resource manuals. In between the calls, we had personalized text, email, messaging, support between calls, and really to support participants in the diet modification. We have a fully designed attention control arm, which we are calling we call the healthy living education. They had the same dose of the encounters of telephone calls over 4 months without the dietary coaching. But we did have 10 healthy living education topics for survivorship that we went through with them during these sessions. They also got text, email, messaging, but more to support the content within the healthy living education. We did use a centrally administered approach, so all of our trained health coaches are located in the University of Arizona in Tucson, Arizona, and was doing all the interventions by telephone calls. And we have been very successful with that. I will be able to share some of that information in hopefully next year when we start looking at some of our data. And we followed up at week 18 and then at week 26. Our primary endpoint is bowel function, and then we have several secondary endpoints, including quality of life, self-efficacy, motivation, positive, negative affect, diet quality. We did and continue to collect 24-hour dietary recalls, so we're going to be able to look at that. And also feasibility, adherence, retention, and acceptability. These are some of the sites that participated in the intervention. Just as a reminder, we did close for step 1 registration enrollment in April of this year. We anticipate that follow-up data will be completed really in the next couple of months, in early November, a couple of weeks early in November. And we are working on a baseline characteristics paper. We did publish a protocol paper early on, and we hope to share some of the data in 2023. Thank you.
Great. I think we need a round of applause. Congratulations, Virginia.
Any questions for Virginia?
So I had a question. So have you already looked at the baseline data and in preparation for the paper? Are there any little tweaks or some prelim stuff that you can say to us about that?
Yeah, we're still working on making sure all the data is ready to be analyzed, and doing some final coding for some of the data. I did want to say that we were very proud to be able to enroll 2 participants from Guam and trying to work out the time zones, but the health coaches were amazing in terms of working out the time zones. And one of the experiences with one of the Guam participants is the telephone, the cost in relation to the use of telephone. We were able to support that. All lessons learned when we're thinking about, the opportunity to do a phase 3 trial once we see our data. So we were able to show that we are able to do this by telephone, even as far as Guam. So we're excited about that, and we'll be able to definitely share some of that information.
That's great. Thanks a lot, Virginia. Appreciate it. We're going to, Dr. O'Rourke's now going to take over and walk us through the pre-SWOG active study updates.
Good morning. It is a pleasure to be here, and there are a number of studies that we have underway, and I will advance the slides, that are in the category of pre-SWOG studies. There are pilots undertaken in the hopes of becoming SWOG studies. The first is a provider communication study. So it's a conscious effort to train providers to improve their communication. Dr. Subaya is the principal investigator, and she's not able to be with us this morning, so I will speak for her. She and Dr. Feldman developed a questionnaire on self-efficacy in communication for seriously ill people, and have validated and published that questionnaire in the last year. And then we're doing this trial funded by the Hope Foundation to take a single arm of providers, enroll them, have them take the online course in communication, and then assess the change in their efficacy in communication. The course is from CAPSI. It is the delivering serious news, discussing prognosis, clarifying goals, conducting a family meeting, advanced care planning conversations. So this is our first effort to improve the provider communication in the hopes of improving the patient experience. The second study I want to mention, a pre-SWOG study, has to do with breast cancer survivors with fatigue. Dr. Lauren Fowler and Dr. Jamie Myers are the investigators, along with the medical student, Shelby Rader. They have developed an intervention of sleep hygiene, as well as wearing a Ready Band watch, a Ready Watch activity monitor, and are looking to see women on endocrine therapy for breast cancer and to enroll them in this trial to wear the Ready Band and see if feedback of that Ready Band helps with the sleep hygiene education to improve sleep metrics and thereby improve fatigue and overall quality of life. And this is, and I'm going to ask Shelby Rader to unmute so we can get her comments. She's the one who's actually been on the ground doing this. People are enrolled, given the watch, remotely activate the watch, and it keeps track of your sleep metrics. And so you can get an idea and gives you what's called a Ready score. And in the first month, you don't get the score back. That's the baseline. And then in the second month, you get this Ready score, and it gives you feedback on your sleep metrics. It's been used in a variety of occupational settings and in the military over 20 years, and there's a tremendous amount of data as to the effectiveness or the accuracy of how well it measures fatigue and decreased cognition because of fatigue. We're going to get 50 participants, and the accrual has been brisk already, and the screening tool is the ISI, and just a comment that it has to be a score of 8 or higher, and all of the people are above 10. It's just amazing how many women with advanced breast cancer have serious sleep issues. And can we unmute Shelby?
Yes, thank you, Dr. O'Rourke. So like you said, my name is Shelby Rader. I'm a medical student at the University of South Carolina School of Medicine, Greenville, and I've had the pleasure of working on this project. The severity of the problem is also indicated by, in pre-study interviews, not every woman necessarily, but many women that we've talked to have gotten very emotional when talking about their sleep and how it affects them, as well as not really understanding or knowing where to go for that care. Do they talk to their primary care provider? Do they talk to their oncologist, their nurse navigator? So we already have some great directions for this project to go. Additionally, we have been asking them some qualitative questions in the REDCap survey that we are using in between study periods with the actigraphy watch. And those results are preliminary, but are showing that this really matters to women and to patients in this particular population, in that they, the vast majority of our participants are stating that they value this conversation being had within the medical context, within the clinical encounter. And so I think that not only will this study give us some really good quantitative data from the watch, we will also be able to pair that with the qualitative data that we're getting from these surveys and hopefully have some really valuable information.
Very good. Thank you very much, Shelby. And it'll be nice to use this Ready Watch feedback as a kind of an objective measure of subjective fatigue and sleep disturbance. The next pre-SWOG talk to mention is sleep hygiene, and again, using the Ready Watch for men with advanced prostate cancer. This is a study developed by Dr. Myers is with us today. Jamie is here, and in the interest of time, I'm just going to briefly say that she has developed a study, gotten it funded by the Oncology Nurse Foundation, and it will do an intervention of sleep hygiene and wearing the Ready Watch for men with prostate cancer on androgen deprivation therapy, and randomize some to get cognitive behavioral therapy and others to get the usual care. It is in the process of going through a regulatory in Kansas City and in Greenville, and should be accruing this fall. Let me just go through these. And we're not, in the interest of time, we're going to go through these, but Dr. Myers will have a lot to say about this next time around. And now I can step down.
Okay, so I'm going to give a very brief update on S1316, which completed a couple of years ago. Remembering it's the malignant bowel obstruction study with a randomized and non-randomized component. Every patient had to be surgically eligible with equipoise. And those are the final accrual numbers. Actually, this is not the, somehow it changed, but also the final numbers that were eligible for analysis is slightly different, a little bit less. So basically, I'm going to give a little bit of the outcomes. This has not been published or shown elsewhere, so please keep it to yourself. As far as there really was no difference that we saw in the main primary outcome measure with Good Days. Good Days is out of the hospital and alive at 91 days or 3 months relative median survival. There's no difference in the ability to eat, no difference with NG2, which is a common outcome measure that you see in the literature for malignant bowel obstruction. Of interest, we looked at, so we used two quality of life surveys in this study. One of them was the MD Anderson Symptom Inventory GI, and also the SF or the EQ5D. For this particular analysis, we only looked at the malignant bowel obstruction specific items that affect quality of life from the MD Anderson Symptom Inventory: nausea, vomiting, bloating, pain, and constipation. And as you can see, that there does seem to be an indication of benefit for the surgical arm. And this, as you can see on the far right, the p-values for the combination of the randomized and non-randomized components. So while we're not able to show a benefit, at least at 91 days for the primary outcome, there does seem to be some benefit for an operation, and this is potentially can be practice changing. And so we're pretty excited about this, and we're in the process of getting ready to submit for publication. Survival, just to show you, is really, there's no difference. We did it two different ways: by pathway, meaning randomization versus non-randomization. Interestingly, if you look, the line a little bit above is the patient choice. And, you know, one would think with some of the bias and maybe how the surgeons, there's the surgical teams influence a patient, that those patients would be sicker not to be in the randomized arm, but in fact, that didn't show to be. Surgery, there's an indication the line is a little bit above the non-surgical management, not able to reach significance. So we have a lot of things. We're submitting the primary manuscript. We're working with Mary Lou Dweck. I don't know if anyone knows her. She's at the Mayo Clinic. She was a disciple of Jeff Sloan, who unfortunately passed away, and was the lead on some of these quality of life outcomes. And so she's going to be taking actually a lead with these analyses. We're very excited about that. We're working on a lessons learned analysis, ovarian cancer focus. We'll work on healthcare utilization. And then importantly, we're going to do some very specific, we have an opportunity of over 100 patients who had an operation to sort of see if there's some indicators of that population. Okay. Any questions?
Happy to take a question.
All right. Do we want to call to?
Yeah. So we are moving along nicely. Thank you. And our new concepts.
Okay, so Jay, you're there?
Yes.
Okay, so this is to our IT people, so he's going to share his own slides now. Okay.
You should be able to share screen.
Okay.
You know how to share, right?
Yeah. I think I'm sharing.
Yep.
Okay.
The IT folks, hang on one second,
We don't
because
see
they're
it.
getting it on their screen and then they're putting it on ours.
There you go, you're up.
Okay. Well, thank you so much for allowing us to share our proposal or concept. Before I begin, I just want to congratulate Dr. Krause on completing accrual for that study. I'm amazed because it seems like a very difficult study to randomize patients to, and I thought that was a really innovative study design where you had randomized and non-randomized arms. So congratulations. We wanted to discuss a proposal for a randomized trial of a telehealth-based self-management intervention for diet-related symptoms after gastric and esophageal cancer surgery. So a bit of a background. Surgery is the most common curative treatment for esophageal and gastric cancers. And both these types of cancers, typically the operation to treat them requires removal of either all or part of the stomach. And this causes a lot of dietary symptoms and changes that can actually be long-term or permanent and really result in a decline in quality of life related to eating. And this has additional impacts beyond just the quality of life. There are the physical impacts of weight loss and health associated with nutrition. Patients who lose weight are less likely to complete adjuvant therapy for their cancer. And there are a lot of studies that show weight loss and sarcopenia actually is associated with worse cancer prognosis. So a few years back, Virginia Sun and I and some other colleagues actually did a needs assessment in this population, looking at what types of symptoms patients have and the ways that they were addressing those symptoms. So one thing to know is that symptoms vary very widely among patients. Like some patients, their primary symptom might be nausea, others have early satiety, others have diarrhea, bloating. It runs the gamut. So no single symptom dominates. And if you talk to patients, most patients eventually get to the point where their symptoms are fairly well managed. And you'll find that patients generally get to that point through modifying their diet, meaning the most common intervention, most common strategy that patients adopt is just changing what they eat or how they eat. And it's not so much like, there's not like a certain medication that tends to work best or surgical intervention. It's basically diet modification. And patients arrive at this through a system of trial and error, and it's not, and they rarely get coaching or advice really targeted at this diet modification. and it's not a structured way to go about it. It's a little bit haphazard. And so, we really looked at this and thought that perhaps the self-management chronic care model would apply well to this, because it's worked really well for other diseases, like, for example, diabetes, where diet modification is an important part of therapy. And self-management has really been shown to work much better than traditional education. Like, the self-management model works much better than just telling patients, well, don't eat this, eat these things instead. That generally doesn't work very well. But if you give patients the tools to manage their own diet, then that generally works much better in the long run. So with that in mind, we designed a pilot study, and it was a randomized pilot where we looked at patients. So the eligibility was patients who had recent curative intent surgery for gastric or esophageal cancer. They were over the age of 21. And we did the intervention in English, Spanish, and Mandarin Chinese. And the intervention consisted of a handbook and resource manual that included a food and symptom diary, other nutritional information. But the main aspect was 4 telehealth sessions that were delivered by a nutritionist trained in self-management techniques and self-management coaching. And the telehealth sessions were delivered over 4 months. So there was one session at the baseline, and then another session 2 weeks later, another session 8 weeks later, and another session 4 months after the initial one. And keep in mind, this was just a pilot study. There were 26 patients in each arm. So it was not powered to be able to show a statistically significant difference. But the main outcome we were looking at was quality of life measured by the EORTC QLQ C30 at 6 months. So we looked at quality of life at baseline in 6 months. And what we found was that there did seem to be, so if you look at the subscales, the control arm actually did a little bit better in the physical functioning subscale. But for role functioning, cognitive functioning, emotional, and social functioning, those subscales, all the intervention arm had more improvement. You see that over time, the control arm also improves. Like, everybody tends to improve over time as they get farther out from surgery, but the improvements seem to be greater for the intervention arm. Again, these differences are not statistically significant because the study, as a pilot study, was not powered to show that. And then we also looked at the EORTC OG25, which is a set of 25 questions that specifically looks at symptoms related to esophageal and gastric cancer. And what we found here in the QLQ C30 is that it seems like the role and the social functioning subscales, there was the biggest difference. And kind of along similar lines, when we looked at the questions specifically related to the OG25, the symptoms that are more related to those things, like anxiety around eating, body image, eating with others, those are the things where also the intervention arm seemed to have more of an effect. Again, not statistically significant and not really powered to show that, but we seem to be picking up some signal here. There may be some trend, and I think it's encouraging for us to move forward with a larger randomized trial that would be adequately powered to show a difference. So our proposal is a randomized trial with similar criteria. So curative intent surgery for gastric or esophageal cancer. We want to reach the patients early. So within 30 days of having initiated oral intake after surgery, adults, English, Spanish, or Mandarin. Mandarin, and these are the languages where we have nutritionists who are trained in this intervention, but also it's actually like looking at the demographics of gastric cancer in the US. These are the most common languages, primary languages that patients speak. And then ability to participate in telehealth. And it would be a randomized study. We would do a baseline assessment. And then again, the intervention is this food and symptom a resource manual with a diary education on how to do the food and symptom diary, the telehealth self-management sessions, and then the control group, we're calling it enhanced usual care. So they would get basically just a handbook that has from the NCI kind of eating hint. They call it the eating hints booklet that gives general eating advice, but it does give advice about what to eat when you have certain symptoms and things like that. And it's really designed. The handbook is designed for patients with cancer or undergoing cancer treatment. So the intervention would be centrally administered. And again, it's telehealth. So it could be, I think it's really quite scalable. And then we would do 6-month assessment. And really the primary outcome would be the quality of life measured by the EORTC QLQ C30. But secondary outcomes, we would also look at the OG25, the PROMIS measure for self-efficacy, and we would also be looking at objective measures of nutrition, including weight, albumin, and sarcopenia. And with that, I'd be happy to answer any questions.
Thank you, Dr. Kim. That was wonderful. A round of applause here. You can hear it. I'm going to take Chair's prerogative and ask the first question. The sexy outcomes that you reported in your graphs are great. I'd love to hear more about the more mundane feasibility outcomes. Can you comment on the completion rates of the intervention instruments? And also, if you have any comments about how many patients who were enrolled utilized the Mandarin option.
Yes, so if I remember all the questions, in terms of, right, it was mainly a feasibility study. So those outcomes are really, I guess, for us, the primary outcome. And the reason we did it as a randomized trial, even though it was a pilot, was to show that we could enroll patients in a randomized study. And so we were able to enroll about 80% of eligible patients. And then the completion rate was actually similar for both control and intervention, and it was about 75%. In terms of
for the intervention as well as for the instruments, or
completion rate, meaning completing the getting to the 6-month assessment and completing the assessment at 6 months.
Great. And I asked you if you would comment on the number of patients that took advantage of the Mandarin.
Yeah, so our patient population is in LA is very, very diverse. And we found actually there were only, even though when we did the initial assessment at our population, Mandarin Chinese was like the 3rd most common primary language. We only ended up having, I think, like 2 patients that were Mandarin speaking. And we find that it's like English is number one, Spanish is number two. The Mandarin is like a distant third, at least in our population. And then kind of almost tied with Mandarin is Armenian, Korean, Cantonese, and a whole slew of other languages. So there were only a couple of Mandarin speakers.
Great, thank you.
So our coaches are trilingual, bilingual. There is not translator, in the process. And so, and all of our staff are able to communicate native speakers in terms of the intervention as well as the data collection.
That's great. And are there materials that had to be translated as well?
Yes. So we did have, Jay, go ahead.
Yeah, go ahead.
You
Yeah.
can do it.
Yeah.
So we did translate them, and we did take the opportunity to have it be reviewed by some of our patients before we actually finalized it and used it in the pilots.
Sounds like a great paper.
So-
I don't know if it's the only study that has Mandarin patients in it. It certainly is in our committee.
Well, just to finish up, and so the future goals of this is to submit a grant and move forward within this committee. Is that right, Jay?
Exactly. I think we're really looking at the R01 mechanism for funding. Yeah.
So we have an extra 1 minute. So Mark's going to speak to our next two new concepts by calling Dr. Feldman up.
So yeah, we're going to have our plenary speaker, and I have just a slide for Dr. Feldman to talk about his work with the HOPE workshops. And Dave, come on up. Let us give you just a minute here to tell the story. But he's developed these 2-hour single session workshops that he's rolling out a clinical trial of pilot studies in patients, women with breast cancer on endocrine therapy, and also faculty and medical providers. And so we're going 2 different directions with the HOPE intervention. And I'm glad we have just a few minutes to let Dr. Feldman tell a story.
Sure. So I actually didn't realize that I was going to be asked to come up and talk about this, but I will just sort of update you. You have heard us at various of these meetings before.
Here, you get one slide.
Okay, you've heard us at various meetings before talk about the HOPE workshop intervention. This is a single session, 2-hour intervention that we've actually now published and is sort of evidence-based with a variety of different populations. But there are 2 populations that we particularly are interested in. One is physicians and healthcare professionals who are facing burnout, because in some sense, HOPE is sort of the opposite of burnout, right? Burnout is the idea that, well, there is no hope. There is no way you can accomplish important goals and objectives in a work context, whereas hopefulness is just the opposite. It's the idea that, in fact, you can accomplish important goals with the right strategies. We're also interested in applying the HOPE workshop, HOPE intervention, to women with metastatic breast cancer who are on endocrine therapy, which, as you all know, leads to pain and other serious side effects, which can lead to a sense of hopelessness and also low medication adherence. And we believe that a HOPE intervention might be helpful there. So we have a 1-pager out. It has now been sort of funded, this study, actually thanks to Mark, with some funding from the Prisma Health System in South Carolina. We have a small, about $15,000 to do this, and we're going to begin to recruit. We're actually working on the IRB proposal right now, and we're going to begin to recruit both healthcare professionals and women with metastatic breast cancer within the Prisma upstate healthcare system. Just to give you a sense of sort of where we have been, we've published a few things on this. One you can see here is a Lancet Oncology article that came out in 2020 that actually summarized a lot of the theory, but also the background research linking higher HOPE to all kinds of positive outcomes in patients. But as I said, we haven't really applied the workshop yet. And then also you can see we have a piece in JNCI Cancer Spectrum, very interestingly, where we actually do a bibliometric study where we look at the number essentially of mentions of hope in the cancer literature, finding that particularly in primary research articles, it's actually very, very low, even though when you look in narrative pieces, when you look in editorials, the mention of hope is very, very high. So in other words, cancer researchers appear to care about hope. They're writing about it in the sort of squishier, less scientific venues in a variety of journals, high impact journals, but they're not writing about it in a scientific context. So we want to remedy that by doing more research on this. I hope that summarizes it to some degree.
Those are the two slides. Thank you.
So I will yield the mic back. Thank you.
So, thank you, Dr. Feldman, for jumping in there. So unlike what that slide said, time for you to speak up, it is not. We are going to, I guess we'll say we saved the best for last. With our speaker today is Catherine Ast. Catherine is the Director of Quality and Research for the American Academy of Hospice and Palliative Medicine. She's a licensed clinical social worker, specializes in collaborative, patient-centered, and quality measure development. Before her 9 years at the American Academy of Hospice and Palliative Medicine, which I know many of you are familiar with her from that work, she worked at the AMA and led the development of clinical performance measures for major depressive disorders, kidney disease, geriatrics, and other specialties. She has led several national quality measurement improvement projects since then, including the development of the PCQC, the National Palliative Care Registry, Data Registry, and other national palliative care measurement options. I'm sure she's going to tell us about these. And Measuring What Matters, which was an initiative from the American Academy of Hospice and Palliative Medicine and Nurses Associations. Catherine is pursuing her PhD because she doesn't have enough to do in social work at the University of Illinois at Chicago, focusing on implementing palliative medicine, PROs, and practice. And just on the more personal side, her previous experience includes teaching high school. So this is a perfect audience for this. Clinical work with people with developmental disabilities and providing mental health therapy. She has her BA in English education from Duke and her master's from University of Illinois at Chicago. So Catherine, take it away.
Thank you so much. And thank you all for your grace. I apologize for being late. I greatly overestimated my ability to navigate downtown Chicago, even though I live here, and also figure out which hotel is which. So apologies. I am here today to talk about our 2 new patient-reported outcome measures. And there's 3 things I would like you to get from this talk. And one is the rigorous development process that we undertook to create these measures. And second, along those lines, scientifically sound. They were found to be sound and valid, reliable. They are liked by patients and caregivers. And finally, I forgot point 3. Oh, here we go. I have notes. They're prioritized by CMS. And yes, okay, I'm just gonna move on. So I'm gonna skip around a little bit on the slides. After I gave them to Dr. O'Rourke, I rethought some of the order. So I want to show you the measures first. And they are 2 patient-reported quality measures of outpatient palliative care experience, and they matter to people receiving care. That was the most important thing. So we have the questions that we ask the patients are, did you feel heard and understood by your palliative care provider and team? And did you feel that you got the help you wanted for your pain from your palliative care provider and team? And Why? Why did we develop these measures? Why are these concepts important? And they're important because they're prioritized by patients, families, caregivers, and providers. PROs are prioritized by Medicare. So that's one of the things they came out with their gap analysis, and they were pros, proms, pro-PMs, and palliative care, lucky us. And then the measures are needed for the merit-based incentive payment system and alternative payment models. So that was really important. Our palliative care clinicians have not had meaningful measures to report on for those quality payment programs in quite a while. So it was important to have something meaningful. And pain is one of the concepts that patients could really wrap their heads around. And it represents all pain. We left it intentionally vague in order for the patient to decide what kind of pain were they going to refer to, physical, emotional, spiritual. Because as you know, all the patients experience all those things when they have serious illness. And then communication, we were told by patients, is the most important thing that they want from the medical provider, any provider. So the objectives of the project, you can see it was extremely important for us to incorporate the patient voice and patient preferences, as these are patient-reported outcome measures. We wanted to develop measures that are cross-cutting. So not only appropriate for palliative care, but primary care, specialty care, a lot of places. We convened a technical expert clinical user patient panel. So that's a long name. We called it the teacup. And the latest science is to include everybody in one panel, not to have a separate patient panel, a separate clinical panel, and a separate expert panel. So they were all together, and they gave input directly into measure development, specification, testing, and the implementation process. And finally, one of our goals was to submit the measures to the National Quality Forum, and also for inclusion in CMS's quality payment programs. And we are happy to announce that both measures are NQF endorsed now. So hopefully that will spread the reach. All right, now I'm going to skip a few slides, which I'll come back to. But I'd like to give you the specifications. Oops. Starting with the beta field test. So again, the measures were rigorously tested with a web to mail to phone survey designed during a pandemic. So we did have to stop data collection for about 3 months, but we went back to it, and we were really pleased to find that we had a 40% response rate of surveys, which is quite higher than the CAP survey or other patient surveys that are mailed to the home. So that told us something important about how patients responded to the measures. And I wanted you to see the diagnosis groupings of those who completed the survey, because 60% had cancer. So a lot, obviously, serious illness, the serious illness population comprises or is comprised of many patients with cancer. So I think they're very, very relevant for this field. And that was the third point I wanted to get across, that these measures are in use already. And you'll hear a little bit about that later. And I hope that you will decide to use them as well, at least one. And final specifications of each measure. So feeling heard and understood is a multi-data element measure consisting of 4 data elements. I felt heard and understood by this provider and team. I felt this provider and team put my best interests first when making recommendations about my care. I felt this provider and team saw me as a person, not just someone with a medical problem. And I felt this provider and team understood what is important to me in my life. So because heard and understood is so central to person-centered care, we focused on top box scoring. And there's still room for improvement. Then we have receiving desired help for pain, which is the percentage of patients age 18 years and older who had an ambulatory palliative care visit report getting the help they wanted for their pain from the palliative care provider and team. So it was important to our TCUP that the team was included, because palliative care and really all medical care is a team sport. So even though in the MIPS program, the measure will be attributed to the lead clinician, the team is a big part of the care. And so it was important to them that that be included. And then I just want to let you know, we got feedback from over 200 stakeholders during our public comment period. A number much higher than the typical measures comment period, as I understand. And we were very, really pleased to see the result that providers are likely to use both measures and feel they get to the heart of what palliative care is about. So 83% of providers who responded were very or somewhat likely to use feeling heard and understood. And patients, caregivers, and patient advocates also comprised a large portion of the stakeholders that commented. It was over 30%. In fact, I think I remember 38% of our respondents were patients, caregivers, and patient advocates. And they are enthusiastic about the two measures, with 87% very or somewhat likely to complete the surveys. And they said their patients are primarily excited about the opportunity to drive change and improve the experience for future palliative care patients. All right. So how did AHPM get chosen by CMS to develop these measures? And now I'm going to skip back to slide number 1. So we had been doing some other work in this area, which started with a seminal project, which still has a lot of, let's see, what do I call it? A lot of citations today. I guess that's what I mean. People refer back to the Measuring What Matters project, which is super exciting. But what I want to say about this, again, this was an unprecedented opportunity by CMS for a medical specialty society to develop quality measures with macro funding. And we were privileged to be one of 7 recipients of this funding. And I think it goes back to our Measuring What Matters project and what it is, because it's enduring. It's a consensus recommendation project begun in 2013, my first year at AAHPM, my first project, and published in 2015 as a partnership between AAHPM and the Hospice and Palliative Nurses Association to develop a portfolio of quality performance measures for all hospice and palliative care programs to use for program improvement. So we did designate it as quality improvement, since most of these were not part of quality reporting programs, except there were 2 that were part of the hospice quality reporting program. So here are the top 10 measures that matter that were prioritized by our panels. Again, this was when we didn't know the panel should be all together, but we had a scientific panel, and then we had a clinical user panel, and then we had a public comment period. So we went through all the steps to try to get a lot of input from the field. And we limited the measures to ones that were already developed. So that was another thing. We weren't trying to make aspirational measures or give recommendations for what should be developed, but rather what was already developed. But you'll see with numbers 9 and 10, the last 2 on the bottom, they're really still, our panels felt there still weren't great measures on those 2 concepts. Care consistency with documented care preferences, of course, speaks to communication. And then the patient-family care quality global assessment, we did refer to the VA's bereaved family survey, but we wanted something for the patient. So we also were working on several other projects. We assisted in getting the Palliative Care Quality Collaborative developed and launched. We are not formally part of that project anymore. We're a collaborator. They're their own 501c3 organization now, registry to collect the data on palliative care programs. We also had an AARP Innovative Measure Development Grant where we were working on refining the serious illness denominator. So that is important work, as well as many of you might be working on it in oncology. So our partnerships, we want to make sure we mention American Academy of Hospice and Palliative Medicine, or AAHPM, was the recipient of the 3-year cooperative agreement from CMS, $5.5 million. We were absolutely excited about. And most of that went to RAND Healthcare, our technical partner. And there is a member of our team here today, Dr. Annie Walling, was a big part of the project. And we also partnered with the National Coalition for Hospice and Palliative Care. They were our stakeholder engagement partner. And I'll never do another measure development project without a stakeholder engagement partner, because it was fabulous just to have them always thinking about how to get everybody involved, and kept the communication going. They created a website that still exists. They're going to maintain it as long as we want them to. And so it's so exciting to just say, okay, go to this website and there's everything you want to know about the measures. And then we also partnered with the National Patient Advocate Foundation, and they're the ones that helped us find the patient advocates, patients, and caregivers that were included in our project. And they also helped us do a webinar right before our public comment. So we did a joint webinar where that's how we got so many patients and patient advocates and caregivers to respond to our public comment. All right, we went through this one, so I will skip to what we haven't seen yet. Timeline. Basically, I just wanted to show you this timeline to point out part of the process. There was a environmental scan, literature review, focus groups with patients and providers, cognitive interviews. So there was a lot of pre-work done to validate the concepts and the wording in the surveys. And then after that, of course, we did have a subset of the TCUP, which was called the Measure Specifications Panel. That was the MSP. So they did meet right after the TCUP to hone in on all the feedback that we received and see how that could be implemented scientifically. Measure testing, public comment, and finally, the consensus-based entity endorsement. As I said, both measures are endorsed by the National Quality Forum, and one of them is under consideration for inclusion in the Quality Payment Program. Heard and Understood made it on the list, so we're super excited to see if that makes it into the CMS quality reporting programs. Again, very, very important, critical part of the process, including patients, families, and caregivers. There's 2 of our volunteers on the right who were very vocal, but we did have calls with them before every TCUP meeting to make sure that we heard their input. In case they didn't feel comfortable speaking up with the large group, we got their input in advance and then asked them again. They were pretty good about speaking up on the calls too. We only had 1 in-person meeting before the pandemic, so the rest were phone calls. And we had very good attendance on those calls. I would say 90% of our panel, and we had 30 people on the panel. So it was very, very good adherence to the process. I wanted to just show you some of the feedback we got from providers for Heard and Understood. They said, I love that measure. I think it measures something that is essential to the service we provide. And feeling heard and understood is the first step to understanding the patient goals, and then understanding what they want and completing their documents for final care. So some other comments I won't read: for getting help for pain, and overall programs, the 44 programs that were involved, we're really honored to be involved. That's what they told us. All right, skipping over this. I'm almost done. I want to tell you about the implementation guide that AAHPM developed, and it includes resources for getting organizational buy-in, resources to explain to patients why the data is being collected, implementation strategies, quality improvement resources, and most importantly, recommended survey administration procedures. That's really the bulk of it. The document is about 80 pages and 60 pages are the survey administration procedures. So everything you need to implement in the setting where we implemented. And we did the outpatient setting because of the merit-based incentive payment system. But we absolutely feel that these can be implemented in most, if not all, medical settings and even the home setting, but they'll need to be tweaked a bit. So we already know of many programs and clinical trials that are using the measures. And is Chris on the phone? Kristen McNiff?
I am. Hi. Can you hear me?
Oh, yeah.
Good.
Hi, Kristen.
Hi.
And we'll have one person just talk a little bit about the implementation in oncology. And we have survey materials and advice for choosing a vendor available for free on the AHPM website and also the coalition website. And so here's just a few of the things that are also available on the website: measure descriptions, journal publications, patient-centered approach, why and how to use the process. And again, I thank you for letting me come speak to you today, and contact me at kost@aahpm.org, and I'll walk you through whatever you need to get started. And I hope that you will. And I'm going to turn it over to Kristen McNiff just to talk a little bit about the Improving Goal Concordant Care project.
Hi, thank you. I'm going to be very quick, just starting with a very fast introduction. I'm Kristen McNiff Landrum. I have spent my career working on cancer quality and value programs and policy in a variety of settings, and may have interacted with some of you in my time at ASCO or in other work settings. I'm now an independent consultant, and I have the great privilege of working on the initiative called the Improving Goal Concordant Care Initiative, which you can see displayed here on the screen. In 2020, the Alliance of Dedicated Cancer Centers, ADCC, launched a 3-year practice transformation initiative, IGCC, and ADCC, thank you for doing my slides. ADCC is a member organization of these 10 freestanding cancer hospitals across the country. Doing improvement initiatives is really not the main focus of this organization, but this is the first one that's being done as a widespread practice transformation collaborative. You can see here the vision and assumptions that we are using for this initiative. Just to highlight a few things, the main vision is that all patients with cancers in their family should receive care that aligns with their own values and priorities, and that providing goal concordant care will enhance their experience. We also consider this a primary palliative care model. So the target here is for oncologists, and the assumption that while this is, as has been mentioned several times, a team sport to provide goal concordant care, we are placing the responsibility on the oncologists to ensure that the discussion happens. Just very briefly, there are 4 core components that go into the IGCC initiative. The first is a rigorous communication skills training program for oncologists and APPs. Our centers are mostly using Vital Talk or the Ariadne Serious Illness Program. The second is the building a standardized structured EHR documentation template for goals of care documentation. The third is defining priority populations with whom to have these conversations, and then building automated nudges or decision support for providers. And then the fourth is to participate in collaborative activities, including evaluation and measurement. And I'll talk about the measurement here on the next slide. So we have implemented about 20 measures spanning various aspects of the initiative. And as you all know well, where we have struggled, like many who have tried to do this, is looking at the outcomes, and specifically at the patient outcomes. So we were delighted as we were developing this initiative, which started in 2020, and I should say it's a 3-year collaboration. We were delighted when we were first envisioning the project, defining the conceptual outline, and preparing for measurement to know that AHPM with their partners was in the process of creating heard and understood. So we always had it on our measure concept list. And as we were refining our measure set for the initiative, heard and understood, it just so happens was completing its testing. So the timing worked out very well in that, again, challenging space of being able to measure patient outcomes. We had a variety of measures that we have attempted and are attempting to measure, but there's been huge swell of support for the feeling heard and understood measure, and really more and more, not just acceptance, but enthusiasm and advocacy on the part of our palliative care and oncology leaders that this is the ultimate outcome that we can measure if we're trying to understand goal concordant care. So all of those 10 cancer centers have agreed to collect the heard and understood survey, which has been adapted only to ask about care provided by the oncologist and their team instead of the palliative care physician and their team. We have worked with Press Ganey, who's been a great partner to implement the heard and understood survey as developed including scoring by AHPM and their partners in the Press Ganey surveys. We really targeted ambulatory oncology or the med survey, but our centers are able to pull it into any Press Ganey survey that they use. So many are going to implement in their inpatient surveys as well. We have 4 centers that already are live with heard and understood. And after there, it actually was less than a quarter, so maybe a little bit more than a month, but definitely not a full quarter. We had data from 14,000 oncology patients. Right now, the target is just the general population who receive Press Ganey surveys at these 10 cancer hospitals. So it's not more targeted. In the future, we do want to be able to look at the data for a more advanced cancer population, but we think that there's actually value, and we have some hypotheses around improvement for all patients who receive the survey, or all patients who are being seen and are eligible for the survey. We are very excited to continue to expand this to the other 6 centers and to be able to track this as one of the key outcome measures. It'll be trended on a quarterly basis for each of the centers and for the IGCC aggregate as a whole. With that, I think I will stop and turn it back over to you, Catherine.
So that is it, and would love to hear any questions that you have or comments.
Well, first, thank you.
Thank you.
So while our members are thinking either online, you can post your questions or just unmute. So what do you think is the next step in terms of widespread adoption of this? Is it going to go be equally, do you think, the uptake in both clinical and research settings, or maybe you could sort of wax poetic a little bit about that?
Sure. So our hope is that it is put in widespread practice in clinical settings. And we are working right now with the Palliative Care Quality Collaborative Registry to see if we can obtain some funding to implement the measures through the registry. We think the uptake will be a lot faster that way. Otherwise, AHPM developed a very short survey for those who wish to implement, to let us know so we can help in any way that we can. But I've been pleasantly surprised by the number of people that have contacted us about clinical trials. So I think that's a great way to use the measure as well. But I'm hoping for really to see it happen in practice.
Cheryl Jernigan, I'm a patient advocate. I'm in prevention, but having had my husband who passed away from prostate cancer, who was not really put into palliative care until really late in the process. And there was many times in our care process where we didn't feel we were being heard and understood. So this really relates to me. But I'm thinking about, and to what I felt going through that process. But what I'm thinking about is there anything that is in writing about this that you could share with those of us who are patient research and community advocates so we can help start distributing the information about it to our colleagues? And then it could help promote, the more we understand about it and the value of it, we can help promote that in the trials that we get involved in, plus in our general talk amongst ourselves and in our work with oncologists and others.
Yes, absolutely. Great question. And before we were disengaged with CMS, we made sure to, with the coalition's help, create some materials that can be distributed. So we have a flyer, 2-page with both sides, that I think would serve your needs. Definitely let's talk after this. I did bring my physical cards. So, and you can give me your email address and I'll send that to you.
Is there a website?
Yes, there's a website. I don't have a screenshot of it, but wait, actually, I think, let's see. That's actually the screenshot of the website and the address on the bottom. So like I said, the National Coalition of Hospice and Palliative Care maintains that website for us, which has so much information. I'm sure that the flyer's on there, but I'll have to look myself to see exactly where. I think scroll down a little bit toward the bottom are the important or helpful materials.
And Anne, thanks for coming up. You were going to be on the docket next to speak up and introduce yourself a little bit.
Okay. I was just going to say, hi, I'm Anne Walling. I'm a palliative care clinician, health services researcher from UCLA, and I also work with RAND. I was just going to also say that in case there's people that are interested in the details of the research behind it, there's also testing reports and the information gathering reports, all available on the RAND website too.
Yes, links on the coalition website to the RAND website. So you can find all there's so much material. So hopefully questions can be answered, but feel free to come to me as well and I'll get your questions answered.
And I was just going to say my particular role was helping shepherd through the National Quality Forum process. And the formal testing that was done was within a palliative care population. So I think it's really exciting to also do additional research on the measure in populations outside, patients that are already seeing palliative care. Because I think, like you said, there's an opportunity to think about how we improve how patients are heard and understood at a population level for all of our patients. So I think that's a really exciting opportunity for the measure.
Thanks, Annie.
And Kristen, you're still on, or if you're wanting to chime in, you can just speak up.
Okay, thank you.
Most of you know me, Frank Maskins, as a person who really pushed for the Palliative Care Committee. So my question may be very surprising, which is, should we also be thinking somehow of integrating what appears to be the future, that is the oncology care planning team?
And could you say a little bit more, Frank? You mean on the...
Should we be thinking of using the terminology which has been used here in earlier talks of the oncology care planning team concept in addition to, or I don't think instead of, palliative care? Is that too radical?
You mean in terms of using the measure? I'm not sure, because I know that when you were speaking, Kristen was saying that the measure was being used specifically with the oncology planning team.
Yeah, both in terms of the measure, the name, the thinking about it.
So you're talking about the wording, the terminology.
Yeah, the terminology.
Is supportive care more common in use for oncology? Maybe we could ask Chris to comment if you don't mind.
Yes, I mean, and there are others who have different or more experience than I do, but in my experience, there's kind of a split of use of supportive care or palliative care, and then sometimes other terms to describe those programs. But for the initiative that I'm describing again, which is a primary palliative care model where we're looking to oncologists to be responsible for making sure these discussions happen regardless of who's ultimately involved. We did change the wording for kind of the context of heard and understood to ask about the care that was provided by the oncologist and the oncology team. So that's the context in which the questions are asked for the adaptation of heard and understood. And so far, it hasn't caused any questions or concerns. And again, we've implemented within a new section of a standard Press Ganey patient experience survey. So the patients who receive it are being asked about other aspects of their care. And then there's a new section that was added that is the 4 items of heard and understood.
So I hope that answers the question. So it sounds to me like, though this measure was developed within the context of palliative and supportive care, that it really can be, the stem of it can be substituted with oncology, it could be substituted with the primary team, et cetera. And so feeling heard and understood by whomever your target is that you're trying to evaluate, that it's able to be substituted across.
Yes, it is. And there's also some research and data on its use in the inpatient setting by Dr. Robert Gramling. And so that is another source of data that you can see how it's been used.
Yeah, I think we have to remember that the rest of the world outside people here, which is really a small part of the world, don't think about the word palliative care. They want to hear patient-centered care, something like that.
Great point, Frank. Thank you.
I don't like politics, but it is a political word.
It is. Well, thank you again so much for having me. And yeah, just email me if you have any more questions.
Thank you very much.
So with our last few moments here, we have an opportunity for any other issues to be brought to the committee in terms of new ideas, other studies, anything that you've heard yet this morning. So in terms of that other slide that said, now it's your turn. So now it's your turn. So. And this includes really anybody who is also online. I've been invigorated to see that we have 38 Zoom participants. Between the audience and Zoom, we have over 70 people who are part of the Palliative and End of Life Committee meeting today. And so it's warming the hearts of our collective co-chairs here. That there is that much interest in our an effort. So Frank and all of the other pioneers that got us going, even though we're the rookies, I think we're in pretty good shape. So thank you. Our other officers who are present, and Catherine or executive stats, people want to make any comments about any of the studies? Maybe we could introduce Virginia in her new role.
Has it been formalized? Has it been formalized? I mean.
So it's been announced. So I'd like to introduce and put Virginia Sun, Dr. Virginia Sun, on the spot, who is our new SWOG executive committee member, and maybe you can sort of just step to the microphone and say what that means, if you're sure yet, as it's new.
Thank you. I mean, it's a great honor and privilege to be able to serve you, serve SWOG and all of you. So I am very early in this role, so happy, please come up and, happy to discuss, happy to help, happy to support in any way. Thank you.
All right, well, if there is no other business before us this morning, I'm giving you 3 minutes of your life back, opportunity for bio breaks or whatever, and thanks everyone for making your way here so early this morning. To be continued.
Thank you all.